I'd like to extend my talk to what Dr. Amit Gupta and others have spoken on the lenticular. So refractive and visual outcomes are SMILE using the VisuMax 800. So for beginners, I think we should all understand that there has been a paradigm shift in the refractive surgery, and what used to be flat based has now been lenticle based. So essentially, if you see, there are 4 essential steps in creating a lenticle. So this is the lenticle cut, taking essentially 10 seconds on different platforms. You have a lenticle side cut, 2 seconds. Then you have what is the cap cut, 12 seconds, and the cap side cut, which is 2 to 3 seconds. So we had an access to both VisuMax 500 and VisuMax 800. And on the VisuMax 500, the entire procedure used to take around 28 seconds, vis-a-vis VisuMax 800, which essentially boils down to almost 8 to 10 seconds. So I think speed does matter. When we see on the world platform, there are various now companies which are selling by different names. The various platforms available. But all in all, these platforms are quite comparable. What essentially is the difference is the amount of laser energy shot per pulse, and I think ELITA or the silk procedure usually outscores here. The laser cut time is the shortest with VisuMax 800, where essentially it is 8 to 10 seconds. Though with silk or ELITA, it's a double, you have to dock twice, or you have to have the cup engaging, so the time taken is usually 16 to 20 seconds, and I think shortly with the single device, I think this time will reduce. The patient interface is important, and on the ZEISS platform, we use a curved interface vis-a-vis the flat on the Zimmer or the ELITA platform. Cyclotorsion compensation is a very important tool, as has already been talked about by Dr. Amit Gupta in different, the basic platforms of the SMILE, which was missing on the final platform. And the inbuilt centration, yes, is addressing really the coma, so we'll be talking on this now. And yes, I think SMILE on ZEISS is the only platform which gives you the capability of augmentation. If you have any residual refractive error, you can use the Circle software where you can lift, you can convert the cap to a flap, and then you can examine the residual refractive error. Now the docking is essentially corneal or limbal, so you won't have any red eyes as compared to the silk, where you actually might have a lot of condition. So we did a small study, almost 1.5 years of our experience on VisuMax 800. So the refractive and visual outcomes in patients with myopia and myopic astigmatism who undergo SMILE surgery using the VisuMax 800. So we did a retrospective analysis. So essentially, when you talk about VisuMax 800, I think there are 4 key features which are really working well for this system. Number 1 is the speed. So there is a transition from 500 kHz to almost 2000 kHz, which basically translates to 8 seconds of the total treatment time. Now, what essentially this boils it down to is the chances of suction loss. So world over, the suction loss has in various multi-center study has been reported close to almost 1.53. The chances of suction loss usually primarily occur in the second half. What I mean is in the rate of 14 seconds of the suction, where the patient loses that cooperation, and you end up having a suction loss. Number 2 is the transition of the spot spacing from 4.5 microns to almost 3 micron spot spacing on this 800 platform, and for the lenticle and for the side cut almost to 1.5. Now this essentially boils down to the ease of tissue separation, and that is what translates to day 166 of 2020 vision on the 800 platform. The third is the separation, and the fourth is the cyclotorsion compensation that I'll be partly talking as we proceed on with the study that we have. So essentially we had 1,507 eyes, total 765 patients, 307 male, 458 female patients. And what you notice is 99% of the subjects gave the same visual acuity as their pre-operative best corrected visual acuity at 1 week, 1 month and 3 months. And what is more important is that the vision remained consistent. So the mean spherical equivalent after 3 months post-operatively, 99% of the subjects had almost zero diopter, whereas 1% of the subjects had almost minus 4.5. So what is more important is the results were consistent at 1 week, 1 month and 3 months. So that means the results on lenticular platform tend to be more stable vis-a-vis the examiner platform. Now, when you talk about the safety index was on the VisuMax 800 was almost close to 1.01, and the efficacy. So safety means post-op BCVA pre-op BCVA, and this is post-op UCVA divided by the pre-op BCVA, which is close to 0.94. So the results have been excellent. So we addressed spherical errors from range minus 4.25 to as high as minus 9.75. So this was the only standalone patient who insisted on getting a smile. Our cutoff limit would have been minus 8 in most of the patients. So the mean sphere treated was almost minus 3.9, and the cylinder maximum we could take was minus 4.5. So the range from 4.25 to minus 4.5, the average cylinder being 0.65. So what you see here is the pre-op spherical equivalent from minus 4.23 in our study of 1 month was close to minus 4.12. When you talk of the preoperative cylindrical error, if you talk the mean minus 4.65, post-op was close to minus 0.05. Now what is interesting here is when we talk of the HOAs. So normally the studies on SMILE indicate that there might be increase in the higher order aberrations, but what you note here is in all these 1507 eyes, the mean HOA dropped from 0.31 to almost 0.16. So if you see this cluster, this almost drops down here. And if you see the even median and the range, so this is very, very significant, and I think this is all attributable to the wonderful centration that is provided on the 800 platform. Now if you see the coma itself, if you see the two, this is the pre-operative coma profile and this is the post-operative coma. If you see the mean median, so the mean dropped from 0.16 to 0.1, the median from 0.1 to almost 0.07, and if you see the range from 0.01 to 2.35 was almost close to 0 to 0.75, and this was found to be significant. Similarly, if you see the spherical aberrations, so this is just a cluster which gets the range gets narrow for the spherical aberration, and so there is a fall in the mean median of the spherical aberration from 0.02 to almost minus 4.2. So the range, if you see, minus 1.38 to plus 0.71 went down to minus 4.39 to almost a range of 0.28. This was again significant. So all in all, I think this is the centration which actually plays a key role in tackling these higher order aberrations. One very interesting is in all these 1507 eyes, we just has 2 patients who had suction loss. So that's close to 0.1 as compared to the multi-center study on the 500 platform where the suction loss was close to 1.34%. Now what is this? Because of the speed which actually, the studies by Google have really, come up that the attention span of a human is normally close to 9 to 10 seconds. And if the treatment time, the suction time is close to between 8 to 9, the patient usually responds and doesn't lose the attention, and that's why that is what translates to no suction loss in most of these patients. And very important to mention that these 2 suction losses were, again, these 2 patients are very, very apprehensive patients, and before the surgery itself, we had to actually tell them that if you lose, then you'll have to be, after 3 months, you'll have to take you on a different platform, and actually what happened. So I think with the normal patients in these 1505 eyes, none of the patients had the suction loss. So I think the suction-related complications vis-a-vis on different platforms is almost close to 0 when you are talking on the VisuMax 800 platform. A quick word for the centration that we have been already talking about. I think this is quite descriptive. This is the pupillary center that we talk. This is the Purkinje's and images. This is the quad view. This is the centration target that we are looking at, and this is what actually the treatment has been performed. So this is what you call as the decentration from the target. Now on this 800 platform, very interesting is you take the patient on the atlas, you take the XY, and the XY deviation actually gives you the angle kappa, which is fed on the VisuMax 800. And once you've done that, see what happens is you ask the patient to keep on looking at the green light. So that is actually where the visual axis is, and you're treating on the visual axis. So very carefully, the aim is to get this blue, because the moment it's blue, your decentration is less than 0.1 millimeters. Yellow would be less than 0.2, and anything beyond that would be 0.3 or 0.4. So this is the center mire, and once this infrared camera is on, now this is where you dock. The moment you see the blue, you dock. So yellow means it's close to 0.2. Once you've done that, and then the treatment is actually bang on the visual axis. So I think the study indicates that it's the centration which actually translates to the reduction in the HOAs, the reduction in the coma, and that is what gives you crisp vision day one, and it stands for a period of time. So this is the center line system on this platform, and you all know that if you have a decentered ablation more than 0.3, you tend to reduce ablations, specifically coma and the spherical ablations. And the infrared beam and the docking actually helps you to target right on the visual axis. So this is again a study by Dr. Vishal Janji and his group, which talks of the intraoperative angle kappa adjustment and its role on the higher order aberrations. And this actually clearly concludes that the adjustments of the angle kappa during smile actually results in the lower or the reduction in the HOAs. And this is how might give you a good insight on the reduction of the HOAs. The other feature which in the study helped is the cycle torsion adjustment, and this is still not linked onto the IL Master 700, but slowly this will be incorporated to 700, where we would be without any marking on the cornea, will be able to compensate for this cycle torsion. We all know that this averagely is close to 4 degrees. Various studies say, and the study by Perry's correlate the cycle torsion to be close to 3.3 degrees. Just watch how this takes care in this diagram. Once you dock, you can actually rotate the joystick, and you can actually align this axis onto the two marks on the cornea. So just have a look on this visual here, and so we have done preoperative straight line marking at 0-180. What is important is the mark has to be slightly inside. It has to be not on the limbal, but it has to be slightly conical. And you just see what I did was that I am trying to align. See, watch carefully. This is now being aligned onto the desired axis. So once you dock, you can actually align onto the desired axis, which actually takes care of the cycle torsion. So I think most of the surgical error can be actually treated bang onto the axis required. So just a quick visual of what actually happens in the OR and our the treatment protocol is this. So once you've tried a single drop of paracaine, as pointed out by Sandesh, not too much of drops to be done because you don't interfere with the ocular surface. These are the two arms. This is the sole arm. This is actually the laser delivery system, and this is the interface. This is the graphic user interface here, and this is how the cone comes. This is the treatment cone, and this is the interface, and this automatically has a magnetic, and now you see that this is how you align. You keep on asking the patient to look the green mark, and you align bang on the visual axis. The moment you have 80% of the dock, you apply the vacuum, and this is how this is inside, outside in, and then inside out, and this is the cap cut. The total treatment time almost 8 seconds. What I want you to see is the ease of tissue dissection. I think this is what actually translates to 2020 day one. So this is the entry I do, separate two planes. I go under the cap, over the lenticule, and just watch. So see the ease of tissue dissection, hardly any tissue bridges. You go straight, go left, keep a bridge there, and then gently move on to the right side, separate, and then break this tissue bridge here. And then what a friend Gaurav has taught us, hydrodissection. We did a study on this also. And this is all, and the patient, believe me, 2020 day one. So, better refractive results. Day 1, you're taking care of the higher order deviations, the cylindrical errors, you feed it till 4.5, the cyclotorsion is taken care of, the suction loss, hardly any chances, patients are very comfortable, the vision quality is very good, and the workflow is very easy. There are less surgical and lab OPD hours and peaceful nights to the surgeon. Thank you very much.
Thank you, sir. You made it seem very easy. I just had a question. Do you have any cutoff for doing the marking? We discussed this yesterday for cylindrical powers.
So anything beyond.
My said he does it for every case. Dr. Trey told me he does it for more than 1 hour.
Yeah, so exactly. I was saying that anything beyond -1, we would.